Good morning, ladies and gentlemen. The topic allotted to me for this talk is colloids versus crystalloids in trauma. This subject has been a raging controversy for the last 40 years. From the time I started my training in surgery to the present time when I'm almost starting my retirement, there has been a seesaw movement in determining whether it is safer to give crystalloids or colloids in a severely injured patient. The controversy is because it's a difficult clinical situation to really monitor and come to very clear conclusions. Trials are difficult to conduct and there are many confounding variables and hence the controversy. But we will make an attempt to see what the state-of-the-art information about this difficult topic is. I would like to start with saying that IV fluids are drugs with their own dosage and side effects. I find it quite difficult to understand that when I ask my resident in the ward who has written a routine post-op fluid order, for example, how much of sodium he has given to the patient for the next 24 hours and what the normal requirement of sodium is. Similarly, what is the requirement of potassium and how much potassium has been administered. There is no answer. There is deathly silence. It's because the average resident or doctor does not consider IV fluids like he would consider an antibiotic or an inotrope or whatever else, where he would make an attempt to look at the dosage, its actions and its side effects. That is never done for an IV fluid, but it must be done because IV fluid, believe me, is a drug. The goal in treatment for a trauma patient is to somehow combat what is called the lethal triad, which is acidosis, hypothermia, and coagulopathy. All the three aspects can be adversely affected if the wrong IV fluid is given. This is something we must really bear in mind. The available fluids are crystalloids, colloids, whole blood, or packed cells with blood components. I'll be restricting myself to the first two, which is crystalloids and colloids, because I guess the other two components will be covered elsewhere. When we look at the outcomes about what we have to do, because that's what really matters, first of all, of course, we concentrate on mortality. It could be a 30-day mortality or a 90-day mortality. The element of renal failure takes a very important role as far as the resuscitative fluid is concerned. And of course, ARDS, which is a big killer in patients of trauma. Apart from the lethal triad that I mentioned earlier, ARDS is another thing that we would like to avoid. And of course, we may also endeavor to reduce the ICU stay and the hospital stay, and they will be considered in many trials as secondary endpoints. But the main issue is renal failure and the 30-day mortality. We must also remember that when we give IV fluids, they can worsen the coagulopathy that is induced by the trauma itself, and particularly the colloid solutions are known to give allergic reactions, even anaphylaxis, and that is something that has to be factored into. Look at the value or the appropriateness of either crystalloids or colloids. Please remember that many large trials include data from critically ill patients in the ICU, and invariably they include patients with sepsis as well. It need not necessarily be just trauma. It also includes patients who have been put in the ICU after a major operative procedure or have been put in there after a complication of an operative procedure. And while we are evaluating the value of fluids in trauma, we should not extrapolate the data that comes out of resuscitation of septic patients or post-op patients directly. We cannot apply those data to trauma patients, and so we must focus on what studies have been done with trauma patients and try to come to a decision about what is best for these patients. Normally not discussed in papers, but again of great importance, particularly in a country like ours, is the availability of the fluid and the cost of the fluid as well. If something is good but is very expensive, it may be out of reach of an average Indian patient. Let us look at some of the commonly evaluated fluids. The colloids include hydroxy ethyl starch, gelatin, dextrans and albumin. FFP is not mentioned here, but that is also one of the fluids that is evaluated. Crystalloids include normal saline, Ringer's lactate, and balanced solution like isolate M. We will look at each of these as we go along and see what their individual characteristics are before we get into which of them is really useful in a trauma patient for resuscitation. Hydroxyethyl starch is known to increase acute kidney injury. Many papers, many series have shown that it also increases the need for renal replacement therapy, basically dialysis. And actually in certain countries it is withdrawn from the market. Of note is that it is not marketed in Europe anymore. Gelatin is known to cause increased allergic reactions. While there have been certain noise made about possible increased acute kidney injury, coagulopathy, or increased mortality in some papers, there is no clear evidence for these. Dextrans can be used safely, it is also legal, it is still available in the market, but there is a general lack of data for its usefulness. While its side effect profile may be acceptable, the data in the available trials is generally lacking. Albumin, there is no clear benefit or risk with it as far as the kidney injury and mortality are concerned, but it is very expensive, and I honestly believe that it rules itself out in our day-to-day practice with its cost. Normal saline is an unbalanced crystalloid, high sodium concentration, and if you give a liter of normal saline, you will be giving a lot more than the daily requirement that a patient needs. And this hypernatremia that it can potentially induce, or the high sodium concentration, reduces renal cortical perfusion. It is also acidic in nature with a low pH and can cause, with its large chloride load, hyperchloremic acidosis. Lactated Ringer's solution, Hartmann solution, has a more reasonable sodium level. It has a balanced pH, but is plagued by a low osmolality, and it should be particularly avoided in brain injury in a multiply injured patient. Perhaps the most appropriate crystalloid is a balanced isolate M, where acetate is used for the balance as far as the acid base is concerned. Its sodium levels are near plasma levels, it has reasonable amounts of chloride, and pH, as I mentioned, is balanced with acetate. And it is also osmolality wise closest to the plasma, and so that would be a very physiological fluid to infuse during resuscitation. Now let us look at what has been used and what the consensus view is as far as crystalloids and colloids are concerned. A Cochrane review of 69 studies with 30,000 patients, by far one of the biggest reviews one can get. But please note that this review includes all critically ill patients and not just trauma patients. They concluded that colloids or crystalloids, there was no difference in mortality as far as the outcomes are concerned. Starches, HES, increased the need for transfusion and renal replacement therapy, which means the incidence of kidney failure was more when you use starches. The other colloids, the need for transfusion and adverse events was uncertain. Well, there was some data to suggest that that might be the case. It was not conclusive. In essence, crystalloids are to be preferred to colloids. This is a symposium in 2017 which appeared in the World Journal of Surgery. Multiple authors who gave their version of the issue said that there was no advantage for colloids, and made the point that it was more expensive and may in fact have adverse reactions. And the important thing that was brought out is that unlike what ATLS says, that you need only about 1/3 of the volume with a colloid as compared to a crystalloids, that has been one of their pushing points for colloids, it transpires that that's in fact not true. The ratio is more like 1.5 to 1, which means that there is no great advantage even as far as the volume of the infusate is concerned. Crystalloids has been recommended even in this group as the first choice because it is as effective as colloids and it has lower costs. And they mentioned that the volume of the crystalloid that you infuse is perhaps more important than what crystalloid you use. But again, a balanced solution, as I mentioned, like isolate M, is to be preferred. We'll know a little more about the volume when we talk further on the so-called hypotensive resuscitation. European guidelines are very comprehensive. They make the point that aggressive volume administration increases abdominal compartment syndrome, mind you, increases ACS, coagulopathy, infection rates, mortality and multi-organ failure. Restrictive volume replacement is what is generally recommended, but you've got to be careful when you undertake this in traumatic brain injury or spinal injuries. There you have to be a little liberal with your volume replacement. And they make the useful point that you don't have to wait until you bring the CVP up to normal levels. If you have a person who is receiving a crystalloid resuscitation, in the process of bringing up the blood volume, when there is continuing bleeding going on, it is important to use a vasopressor like noradrenaline and keep the pressure up, take him to the theater and get control of bleeding. You don't have to necessarily wait until the CVP comes up before you start a vasopressor. Of course, they reiterate that the fluid of choice is an isotonic crystalloid solution, a balanced solution, and they clearly indicate that you must avoid colloids because of coagulopathy. We come to hypotensive resuscitation as one of the more recent thought processes in resuscitation. The aim of resuscitation is to restore end organ perfusion, particularly cerebral perfusion has to be maintained. A kind of obsession about a large volume replacement to keep a blood pressure above 100 millimeters of mercury, for example, is probably incorrect. The aim is to attain a reasonable systolic pressure of 70 to 80 and or a mean arterial pressure of 50 so that you maintain the cerebral perfusion, and as you reduce the volume of the infusate, volume of the crystalloid infusate, you will be minimizing dilutional coagulopathy. You will avoid dislodgement of clots because of a higher blood pressure. You will have a smaller incidence of cardiovascular and respiratory failure. Added advantages are that the amount of transfusion, blood transfusion that you need in these patients is less, and you also have a smaller incidence of ARDS. So there are many advantages for having a low volume or a hypotensive resuscitation using crystalloid solution. So to conclude, ladies and gentlemen, choice of resuscitation fluid has been debated for long. Trials give variable results because it is difficult to conduct very well controlled large trials because there are many confounding factors. But within these limitations, the present scenario, the present consensus is very clear. Use a balanced isotonic crystalloid solution, avoid saline, avoid colloids, and accept hypotensive resuscitation until the bleeding is controlled. Thank you very much for your listening.